Welcome to our webinar titled Hapolidentical Transplant for MDS. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window and just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Brian Shaffer, who is a board-certified hematologist specializing in bone marrow transplantation for leukemia, myelodysplastic syndromes, lymphoma, and other blood disorders. His research focuses on the role of natural killer cells and outcomes after transplantation. His goal is to improve the transplantation process for patients via understanding and optimizing the natural killer cells behavior. His clinical interests include improving transplantation methods for patients without a matched sibling donor. With that said, it's my pleasure to welcome Dr. Shaffer.
Thank you so much. I'm very happy to be here. It's my pleasure. My name is Brian Shaffer. I'm the director of the Hapolidentical Transplant program at Memorial Sloane Kettering Cancer Center in New York City. And today I'm very happy to talk about haploidentical bone marrow transplantation for patients with myelodysplastic syndrome. And I've left my email in this cover slide. Please don't hesitate to reach out to me if there are questions that are outside of the scope of this webinar. Certainly at MSK, we've, like many other centers, started to do quite a bit of telemedicine, and we're always happy to reach out and offer second opinions for patients. So don't hesitate to contact me. I'll mention briefly, as a conflict of interest disclosure, I have these financial relationships. None of these are pertinent to information that I'll be discussing today. So what I'd like to do over the next 45 minutes or so is to essentially walk through the details that I would impart as part of a transplant consultation to a person with myelodysplastic syndrome who is thinking about having a bone marrow transplantation. With the caveat that in this instance, we know that the person would undergo a haploidentical bone marrow transplant. And with this, I also have the benefit of slides, which is obviously much nicer than in an office outpatient setting. But essentially, we'll work through this, starting with myelodysplastic syndrome itself, and then essentially working in a clockwise fashion, talking a little bit more about haploidentical donors, a little bit then into the ways that patient fitness is appraised and how transplant parameters are adjusted around the individual patient, and then how all of that sort of consolidated into a transplant plan. So most patients, when they arrive in my clinic, already have a fairly solid grasp of what myelodysplastic syndrome is. Most patients have been dealing with the diagnosis for quite some time prior to our introduction, but I do typically review MDS biology because I think it's important to understand how the disease behaves and how transplant fits into that pathophysiology. Here's a little cartoon, and these little balls will be a recurring theme in this talk. But here they're meant to illustrate the idea that there's inside of our bone marrow a healthy marrow environment where the cells are composed of healthy stem cells, if you will. These are cells that have the ability to turn into anything as the body demands: platelets, white cell, red cell, etc. And these cells are constantly turning over as our body is requiring new white cells, new red cells, new platelets throughout our lives. We know from population-based studies that especially as we age, there is an emergence of stem cells that have acquired injury to their DNA and have taken on genetic mutations or other chromosomal mutations. But these exist in very tiny populations in the bone marrow. There are some causative factors that we know are linked to this process, particularly agents that can damage DNA, be it previous chemotherapy or radiation therapy, or other industrial compounds. But most of the time, these situations arise for reasons that are unknown. And we hypothesize or conceptualize that one of two things occurs in human beings. The first is in the upper sort of direction, where our immune system may recognize an abnormal cell in the bone marrow, be its behavior or other aspects of the cell. The immune system does not like what it sees, and it essentially protects us from these abnormal cells and deletes these cells. And this occurs in the context of bone marrow cancers, but also in a variety of other solid organ malignancies as well. Some patients, either right from the get-go or later in life as our immune system naturally senesces, will start to develop a state where there's a tolerance between the immune system and these abnormal stem cells that form in the bone marrow. And these may expand and may sit in very small populations over the span of many years or decades. And this corresponds with, as I said, population-based data that has recently been generated as genetic sequencing has become more cost efficient and available, and we've been able to explore the presence of these mutations in large patient groups. We have seen something quite striking. So on this right panel, you'll see this incidence of essentially a new clinical entity termed clonal hematopoiesis. And this is a clinical entity where a mutation that otherwise may be associated with MDS or with leukemia is present, but otherwise no outward phenotype that otherwise suggests the patient has those diagnoses as present. And if you go essentially randomly and start looking in people's bone marrows, you will find these mutations in a surprising frequency, which increases slowly as we age. By the time patients are in their 8th or 9th decade, the incidence of these genetic mutations has reached somewhere between 10 and 20%. And it's clear that MDS is a disease that increases in its incidence and prevalence as we age, as shown on the left panel from the SEER registry. And you can see that there's a very clear relationship between age and the incidence of myelodysplastic syndrome. So the way I personally sort of understand myelodysplastic syndrome looks essentially something like this, where over our lives, we have emergence of these abnormal MDS-like stem cells. Our immune system may senesce or otherwise tolerate these cells for reasons that we do not know. Some patients will live out their lives with these types of stem cells in their bone marrow that never cause any problems, and they're just watched or monitored for many years, whether it be in a state of clonal hematopoiesis or in overt myelodysplastic syndrome. Most patients don't require therapy, but a fraction of individuals will have a more rapid progression and expansion of these cells in the bone marrow. They can acquire new chromosomal changes or new genetic mutations. they start to fill in the bone marrow and create an abnormal environment that is unhealthy for normal stem cells to live and to produce healthy blood-forming cells. And this is typically when we see the emergence of a clinical syndrome, if you will, related to the loss of normal bone marrow function. So the idea behind bone marrow transplant, if we were to think of it just in terms of a single slide, is essentially to try and reverse that natural process. If we think that the person's immune system is in some way tolerating these abnormal cells and allowing them to persist in the bone marrow, then a bone marrow transplant, quite simply, is to switch immune systems with another individual whose immune system may not tolerate these cells, thereby essentially reversing this process and restoring a normal bone marrow function. And we'll talk a little bit more as the slides go on about how that is done. But it's important to understand that MDS is an extremely heterogeneous disease. There are a number of different clinical features that are associated with it, but I generally conceptualize it as falling into sort of two broad bins with a significant amount of overlap between those two bins. The first is what I would generally think of as a marrow failure aspect of MDS. And this is essentially where the bone marrow is not doing what it is supposed to do. This is the type of clinical result that typically will precipitate a patient being diagnosed with MDS or otherwise seeking medical attention for MDS. And essentially what happens is that they are found in some fashion on a CBC to have a low blood count of some form or another. And these types of marrow failure syndromes can become quite severe over time, whether it be neutropenia-related problems, issues of low white cell count and infections that can result from that, or the complications of low blood or low platelet concentrations in the blood that require frequent transfusions, which may result in iron overload syndromes or other problems becoming refractory to transfusion support. Another aspect of myelodysplastic syndrome is the prevalence of some of these diseases to transform into a more aggressive type of malignancy, which we typically conceptualize as either being formally diagnosed with leukemia or very similar to a leukemia-like pattern. And this is essentially where these abnormal stem cells carry about a high rate of division. They fill in the bone marrow. The hallmark feature of this pathologically is an increased number of blasts, which are primitive cells in the bone marrow. And oftentimes this is accompanied by an increase in the rate of constitutional symptoms and an increase in the degree or severity of marrow failure phenotype. So I've seen in my career patients that have presented with either one of these bins or another of these bins, but typically patients have some version of both of these to varying degrees. And it's important to remember that MDS, in the treatment of MDS, we have to think about both of these problems as being life-threatening and both requiring specific management strategies. So as I mentioned, MDS is quite a heterogeneous disorder. There are different degrees of risk. There are a variety of prognostic systems that clinicians have developed in order to essentially quantitate that risk and to facilitate medical decision-making. The most common that is in use is the International Prognostic Scoring System, which was revised recently by Dr. Greenberg and his colleagues in 2012. And you'll hear that referred to as the IPSS-R. And I won't get into how exactly this is calculated. There are a number of online calculators. It's relatively straightforward to determine this for yourself using internet tools. But it's based essentially off of the percentage of blasts in the bone marrow, the degree of low blood counts that are present, and the chromosomal rearrangements or changes that are present, some of which can indicate a more significantly worse prognosis than others. The IPSS-R is not built around genetic mutations. This is a type of technology that has emerged more recently, as I said, with the increase in the availability of deep level of sequencing of bone marrow cells. And this is just an example from Dr. Pep Emanuel and colleagues, which was published in the journal Blood in 2013, where they performed genetic sequencing of several hundred MDS patients. And I don't mean for this slide to be a complete overview of the genetic features of MDS, but rather I show this to illustrate the complexity of the disease. There are over 40 recurrently mutated genes that are found in MDS. And if you look at a population, roughly 80% of MDS patients have at least one either chromosomal abnormality or genetic mutation that can be detected at the time of diagnosis. Some of these features are prognostic, if you will, of outcomes, and others are not. And this is an area of active research, particularly whether this paradigm of genetic mutations can be used to tailor therapy to patients. So something for the years to come. The most difficult aspect of planning therapy for patients is arranging the timing of bone marrow transplant for individuals that are fit and eligible for the procedure. This is an immensely complicated decision, and I think it's past the scope of a 1-hour talk to spend a significant amount of time on it, but I will show a few slides in terms of how I sort of understand and conceptualize the process. What I think are the most important tenets of this process are the following. The most important aspect of any care by a physician is to keep in mind that the decision should be patient-centered, meaning as oncologists or hematologists, our goals sometimes can become hyper-focused on eradication of cancer cells. But we have to remember that the real goal of therapy is to improve quality of life, to improve quantity of life, and to address patient goals for what they want for their healthcare. And so thinking about when to offer a bone marrow transplant for MDS should be highly personalized and individualized based on patient goal, patient fitness, and integrated between both the transplant physician and oftentimes the MDS or leukemia specific physician that's managing their care in the community or otherwise. We have to remember that the goal of transplant can be twofold. Going back to that slide a few slides ago, which is that the goal of transplant is to both restore marrow function and reduce the risk of acute leukemia. And we have to keep both of these thoughts in mind as we think about how to plan a transplant and how to tailor the transplant. With that in mind, I wanted to mention this study, which is relatively recently out, and I think is transformative in terms of management for myelodysplastic syndrome. This is what's called the BMT-CTN 1102 study. The BMT-CTN is the Blood and Marrow Transplant Clinical Trials Network, the 1102 study. This was a randomized trial. Patients with higher risk IPSS, MDS were what is called biologically randomized. Those patients that had a matched donor were randomized to be offered transplantation. Not all of them underwent transplantation, whereas those that did not have a matched donor were continued on MDS specific therapies with their clinicians. And this was a long-running trial. It's played out over much of the last decade, and the results were released in the fall of last year. And if you're not familiar with these types of what are called Kaplan-Meier curves, I want to give you a couple of thoughts about these. So on the left is what's called a Kaplan-Meier curve, demonstrating the survival of patients that were enrolled in this trial. So on the x-axis is the time from the time that they went on to the study, and the y-axis is the probability that the patient was alive. And the different colors, black and yellow, are the different groups. It's important to remember that these types of curves in clinical trials do not represent an absolute probability for an individual patient being alive. There are many things that go into enrolling a patient on a clinical trial and how patients are selected for trials versus patients that are treated on the standard of care or otherwise can vary widely between center to center. So I encourage you not to think of this as an absolute statement about survival for MDS, but rather something to use as a comparative tool. You can compare one group of patients in the study to a different. And the cardinal feature of this study was that they found that patients with higher risk MDS that underwent transplantation had a roughly 20% improvement in survival at 3 years. They attempted a subgroup analysis, which you can see on the right. This is called a forest plot. When that center darker dot is to the right of the vertical line, that indicates the transplant was superior in that group, versus to the left would indicate that the transplant was inferior. And in this, they generally found that in all subgroups, be it patients less than 65 versus those older than 65, the duration of diagnoses, the different risk categorizations that they used, there was no group in the context of this trial that did not benefit from transplantation. And finally, and this is work that's still ongoing from that group, but I think is extremely important. They analyzed quality of life metrics in subjects on this study, and they found no difference in quality of life between patients that underwent transplant and did not undergo transplantation. So the conclusion from these authors is that offering transplant to patients with higher risk MDS early in the course of their therapy improved survival, and importantly, did not diminish quality of life in these individuals. And I think this trial is highly supportive of transplantation in that population. You know, as a broad understanding, of course. So if I were to summarize my thoughts in general, is that I agree with the 1102 trial results. I think transplant generally should be considered early in the management of patients that have higher risk MDS based on either the IPSS or the IPSS-R, which I showed you. You may have picked up that these were data from matched donors, and we're not talking about matched donors here. We're talking about haploidentical donors. So do these data extend similarly to patients with haploidentical donors? And right now, that the answer to that is unknown, but I personally believe that it does. How to manage patients with lower risk IPSS is less clear. In general, my feeling is that patients that have severe transfusion dependency, despite lower risk MDS, should generally consider a transplant earlier in their course before they develop significant complications of recurrent either blood or platelet transfusions. But this is a highly individualized decision, and each patient should speak with their clinician you know, about their management. The main thing I would encourage patients and their families to consider is to think about having a bone marrow transplant consultation earlier in the course of your management. Oftentimes patients, particularly those with lower risk MDS, they'll not be offered a transplant consultation because the thought is that it's not appropriate for you at this time, or many other reasons. And that may very well be the case, but I find that when I have a chance to get to know patients a little bit and follow along, perhaps mainly as an observer or a sort of third party to their care, sometimes for years at a time, ultimately it's much easier to manage patients when the time comes for transplantation. So I encourage patients and their families not to think of a transplant consultation as a moment where you have to go to transplant, but rather a chance to just get to know the transplant physician in your community, and to have a chance to build that relationship over time. And if you don't go to transplant, ultimately there's nothing that's lost. And I think as a transplant physician, I would rather see every patient with MDS and just get a chance to know everyone earlier in their course. So we'll move on now and just talk a little bit about haploidentical donors, and I'll try and speed up a little bit in the interest of time. So there are some key questions about haploidentical donors. How are donors matched? What is a haploidentical donor? Inherently, when patients hear that we're talking about a mismatched type of transplant, it sounds like it should be worse. And there are specific reasons why it is not. And the question always comes up is, are there some haploidentical donors that are better than others? So donors are matched via a series of genes that are called the human leukocyte antigen gene complex. And these are abbreviated HLA. They are central mediators of our immune function. Immune cells use HLA to distinguish self and non-self. So this is how the immune system identifies things that are foreign and initiates immune attacks, including microbial pathogens, viruses, bacteria, fungus, and otherwise. But between human and human, our HLA profiles will differ considerably. And so human, allogeneic or different human cells will seem foreign to our immune systems, and we will innately try and reject these types of cells. So on the left is just an illustration of chromosome 6, which is where the HLA locus resides, and I show this to you just to illustrate the immense complexity of the different genes that go into the immune system in our bodies. Practically speaking, there are a few genes that it seems by evolution have been driven to quite a disparate amount of diversity, and you see these on the right panel with HLA-A, B, and C, and this other HLA-DRB1 having a considerably larger amount of diversity than others. And these are key loci when we're thinking about trying to match both siblings and unrelated individuals to the patient. So we get one chromosome from mom and one chromosome from dad, so everybody has 2 copies of A, B, C, DRB1. So when you're trying to match an unrelated donor, then you're thinking about trying to find a donor that is matched at all 8 of these loci, 2 of each of these 4 areas. And the main unrelated donor repository in the United States published this very compelling paper in 2014 where they looked at the availability of fully matched donors and broke it down by different race or ethnicity of the recipient. And what you'll see here is the blue bars represent the probability that there was a fully matched donor available, and then red, green, purple, and yellow were falling degrees of HLA match. And you can see obviously that patients that self-identified as being of Euro-Caucasian backgrounds had roughly a 75% likelihood of finding a fully matched unrelated donor, whereas individuals that did not self-identify from that background, you can see have significantly lower probabilities. And this goes into the sort of immense biology behind how HLA diversity is established and maintained within populations. But nevertheless, what we have determined is that first, number one, at least 25% of Euro-Caucasian patients will not have a matched unrelated donor, and that percentage rises considerably in individuals from racial or ethnic minority backgrounds. So having an available HLA mismatched donor that is safe and effective is a key tool for people of all different backgrounds, particularly those of non-European background. So when we think about related donor matching, we're thinking again going back to chromosome 6. And the genes of our immune system that reside on chromosome 6 can be thought of as what's called a haplotype. And haplo is a Greek word for single. So as I said, we get one chromosome 6 from mom, one chromosome 6 from dad, and we pass on one of these chromosomes to our children. So imagine our chromosome 6s with their corresponding immune genes like this in different colors used to represent different haplotypes. So if you think about a mother and father, their children have 4 different possibilities. You can see the different combinations of colors that they could land in. So if you think about siblings, for example, if they happen to share one of these 2 haplotypes but not the other, then their immune genes will be half matched or haplotype matched. And so children number 1 and child number 2 shared this blue chromosome, and those individuals would be haploidentically matched. And this graph also illustrates why siblings would have a 25% chance of being fully matched and a 50% chance of being haploidentically matched. If a sibling happens to land in the same quadrant as you in terms of chromosomal inheritance, then you'll be matched. And the other important thing to recognize is by obligation, children should be haploidentically matched. They will inherit one chromosome from their parents. So when we think about related individuals and their probabilities of being haploidentically matched by generation, it looks a little something like this, where parents should be close to 100% matched. There are a couple little things that can occur that would reduce this to something like 98 or 99%. But parents will be almost certainly haploidentically matched, and children similarly will be haploidentically matched. Whereas siblings have a 50% chance of being haploidentically matched. And as you can see, other what we would call third-degree relatives carry similar or lower degrees of matching. This should actually be 25% here. But the key point is that there was an analysis by Johns Hopkins and others where they looked at the degree of relation and whether this influenced outcomes, and they found that there was actually no real relationship between whether it was a parent, child, or otherwise that was used for donation. So if a grandchild, for example, is haploidentically matched, this generally should be an acceptable donor or considered as an acceptable donor as a child, for example. Similarly, nieces and nephews that are haploidentically matched are also acceptable haploidentical donors that should confer a comparable outcome to children or parents. So I'll move into these last two questions. So when I was in training for biology and medicine, I sort of thought of our immune cells as being sort of similar to like police officers, where they would patrol an environment and would recognize something that was abnormal, whatever that thing be, and they would respond to that in a way that a police officer would respond to that. And I think this is how most of us think of our immune system, but it turns out to actually to be almost completely wrong. Immune cells are actually highly specialized, and that biological process is referred to as restriction. So an immune cell in our body is actually going to be very focused on a single HLA. And the diversity of our immune system comes by the fact that we have essentially billions and billions of different immune cells all recognizing different things. It's important to recognize that immune cells are extremely sensitive to chemotherapy, whereas stem cells are much less resistant. Stem cells are extremely hardy cells. So taking these two sort of biological points in mind, some investigators at the Johns Hopkins University approximately 2 decades ago had what I think of as a very simple and very elegant solution to how to prevent graft versus host disease in haploidentical transplantation. And so you would conceptualize it loosely like this. If you think of a transplant product from a donor on the left as having stem cells in green and immune cells in blue, and we'll call this tan, what that means is that immune cells from a half-matched donor, half of those immune cells will recognize HLA that the donor recipient share. And these immune cells, when transplanted into a recipient, are going to be totally fine. They'll recognize the HLA environment. They'll be quite happy there. They should not be activated in that scenario. Whereas these other immune cells perhaps recognize the haplotype that is not shared between the donor and the recipient. These types of cells will be activated when they encounter something that they don't like. And when an immune cell is activated, the first thing it's going to do is take out its DNA, start making different proteins that it's going to use to engineer an immune attack. And that process makes them uniquely susceptible to chemotherapy. And so the solution that was devised by these investigators was to give a dose of chemotherapy known as cyclophosphamide on days 3 and day 4 after the transplantation occurred. So essentially you infuse the donor stem cell product. One part of the donor immune cells will become extremely activated, whereas another will be resting because they're happy. And the cyclophosphamide essentially deletes these activated cells, leaving behind resting cells and leaving behind stem cells. And this donor allograft product will behave similarly in terms of graft versus host disease probabilities and other transplant complications as a matched donor, hypothetically speaking. So this is a demonstration of an extremely common transplant plan that's used for haploidentical transplantation, and this illustrates how there is a conditioning chemotherapy that occurs over 6 days prior to the transplant. This one involves both chemotherapy and radiation treatment. There's an infusion of stem cells, and then you'll see there's nothing here, followed by 2 doses of chemotherapy as we discussed, and then normal medicines to prevent rejection are instituted thereafter. This type of approach is used in roughly 90% of the haploidentical transplants that are performed in the United States at this time. There are different types of chemotherapy that may be used to prevent or treat the patient prior to transplant. We'll talk a little bit about that in coming slides. But this post-transplant cyclophosphamide, as it's known, is the most common modality and the most effective modality to facilitate a haploidentical transplant. And it's also worth noting that this paradigm can be used in both mismatched unrelated donors with what appears to be similar results, and it's currently in testing for matched donors as well. And that trial, which is ongoing, should be of considerable interest to the field. So I won't, in the interest of time, get into a lot of trial data, but what I will say is that there's a large number of retrospective studies that demonstrate similar outcomes in haploidentical transplant patients that are treated with this post-transplant cyclophosphamide, I've abbreviated PTCy here, compared to both matched siblings and matched unrelated donors that use other methods. There was recently a study that was conducted by the main transplant research registry that suggested that older individuals may have a slightly inferior outcome with haploidentical transplantation compared to patients that were of younger age. But I think this is a study that requires more follow-up to really consolidate these results. So whether this hypothesis is true in all patient subpopulations, I think is an open area of research. But as a group, transplant patients have similar outcomes between haploidentical transplant with PT-SI and other types of donors and GVH prevention approaches. So with this advent of this PT-SI methodology, essentially what has happened is that the number of haploidentical transplants for all indications has exploded, both in the United States and Europe. And that's represented by the green bar on the left in the United States and this orange bar on the right in Europe. And you can see that there's been, over the last decade, a nearly 300% increase in this transplant activity in both of these geographic regions. And this continues through the current time. So a question that often comes up is that patients will have a number of different haploidentically matched donors, be it they have several children that are all matched in a fashion or otherwise. And there is often a question of, well, which donor should I choose? And this question was asked by a group of investigators. So they queried the large transplant registry to look at different factors that may contribute to outcomes. And the main signal that came out of this trial is that patient age is a strong predictive factor. I'm sorry, donor age is a strong predictive factor for outcomes in haploidentical transplantation. So younger donors tend to have better graft performance, and the incidence of what's called non-relapse mortality, i.e. death from a cause that's not related to the cancer, that is related to the transplant itself, was more frequent in recipients of older haploidentical transplantation. On the left is a XY plot where it shows the donor age next to the recipient age, and they break this down by generations and color. And essentially what you can see is that when you use a child donor, the donor was younger compared to the recipient age. That of course makes sense, compared to a sibling or a parent donor. And in the right bar, what you can see over time is the incidence of death without relapse broken down by recipient age and by donor age. And what you can see is that three of these lines generally cluster together, which are younger recipients regardless of donor age, and then older recipients with older donors sort of emerge as this purple bar with the higher incidence of transplant-related mortality. And so I think of haploidentical donor age as being an extremely important factor to consider when planning a transplant. There is not a single age that we use as a cutoff to say that this donor is no longer eligible. I think of it as a linear risk predictor. And in general, if we can find a younger haploidentical donor, that is where we focus our efforts. What remains an open question is whether, for example, if a patient only has a matched sibling donor that's in their 70s, and then they have a child haploidentical donor that is in their 30s, which should I choose? And I can't give you an answer to that question. That's something that I myself am very, very curious about as well. Hopefully research in the coming years will help to clarify this issue. A second, and I think the second most important issue to consider when thinking about haploidentical donors is this problem of what's called donor-specific anti-HLA antibodies. So as human beings, if we have seen cells from other human beings' immune systems, whether that be in the context of pregnancy or in the context of blood transfusions, we can become vaccinated to other human beings essentially and start to make antibodies against HLA that is foreign to us. And so if you look under the microscope at stem cells, what you will essentially see is that they express quite a bit of HLA. And if a person has an antibody that is directed against that specific HLA, what happens is that these stem cells can become coded in antibodies upon their infusion into the patient. And this targets them for immune-mediated deletion before they can what's called engraft and begin to produce blood-forming cells in the patient. So it is a critical component to evaluating a donor is to evaluate whether or not there are any HLA antibodies in the patient prior to transplantation. It is a known causative mediator of donor rejection when there is a presence of a high titer donor-specific antibody. What's a little less clear is whether low titer antibodies are clinically relevant. We do see these in quite a number of patients where they have very weak or very infrequent antibodies in their blood, and we have proceeded successfully with transplantation in several of these types of cases, but this is something that I think requires further research. But what is established is that if you have a high titer antibody against your donor, you should be very cautious about proceeding with that type of transplantation, and discuss that with your transplant specialist. But at our center, we generally believe that all patients that are undergoing any type of HLA mismatch transplant should undergo an evaluation for donor-specific antibodies within roughly 3 months of the transplant. More typically within 1 month of the transplant, we try and order this test. Some factors that will predict for a greater likelihood of DSA being present are the relationship and the gender of the recipient. We have found ourselves and other groups that when using a child into a mother vector of transplantation, that the incidence of DSA is quite frequent, up to 80%. And this is logical. I mean, mothers can frequently become vaccinated essentially to their children during the pregnancy process or otherwise. But independent of that, women are more likely than men to make anti-HLA antibodies for reasons that are unknown. All told, roughly 20% of women will have some type of anti-HLA antibody directed at their potential donors versus around 5% in men. Another predictive factor to consider is that patients that require frequent blood transfusions are more likely to become vaccinated against HLA. And so this is something I think that you should discuss with a transplant physician. You know, as you're getting ready for transplant, I think it's important to evaluate for donor-specific antibodies, just to make sure that you can minimize the risk of rejection in the context of a haploidentical transplant. In the interest of time, I'll just mention briefly that stem cells can be harvested in different ways. They can be essentially siphoned from the blood after mobilization, or they can be directly removed from the bone marrow. And this will affect how the transplant behaves. Asad Bashi and his colleagues at Northside in Atlanta examined a large cohort of patients that received blood versus marrow grafts, and in a context of a haploidentical transplant with PT-Cy, and they found that the outcomes followed a pattern that's similar to other types of transplants, where blood type of grafts tend to be more immunologically competent. They produced a greater degree of graft versus host disease, which is the donor versus host type of rejection, but they also were better at preventing relapse. And so outcomes were very similar between a bone marrow and a blood-derived graft, but for very different reasons. And so I think that this is the type of parameter that can be manipulated at times, very specific to patients, and it's something that's worth discussing with your transplant physician, you know, prior to the transplant. So just to put it all together, you know, every patient that undergoes a transplant should have an evaluation for DSA. We generally favor younger donors if they're available. It's an open question whether, if you only have older haploidentical donors, should I use a mismatched unrelated donor or another type of donor such as cord blood? These questions are open and active areas of research. Blood versus marrow grafts, as I said, is a personalized decision. And I also mentioned that there are some ethical considerations when considering using minor children of yours for haploidentical donation, and that's something that you should discuss closely with your physician. So I'll talk briefly about fitness. I'm already over my time. I'll try and get through the high points of this. So the main tool that's used by transplant clinicians to think about patients and their eligibility for transplant is something called the Hematopoietic Cell Transplant Comorbidity Index. It's more cleanly just referred to as the SOAR score. It was first described by Mohammed Soar and others at the Fred Hutch Cancer Research Center. And essentially, this is a way of developing a numeric index to capture patient comorbidity. So prior medical problems and other issues that may affect your overall health status causes you to have an increasing score. And these investigators found that as the score increased, the risk of transplant-related mortality increased. And so most of the time when I'm thinking about patients and working patients up prior to transplant, a key portion of that is to determine their SOAR score and to discuss with them, different aspects of the transplant and how we can attempt to minimize the risk if they do have a high SOAR score. So I think this is something that's worth bringing up with your clinician. One of the key factors that we do manipulate around SOAR score is the conditioning intensity. So chemotherapy prior to transplant is called conditioning. It has two specific goals. The first is really to take a whack at myelodysplastic cells. You want to try and use chemotherapy to just get those guys out of there. And in the process of doing this sort of proverbially opens space in the marrow, if you will. It reduces the number of recipient stem cells that are there that make a biological space, a room, if you would, for the donor stem cells to engraft in the marrow space. The second specific goal is to reduce the recipient immune function, which helps to prevent rejection, recipient versus graft rejection. So there's a fundamental relationship between the intensity of chemotherapy that you get prior to transplant and the risk of relapse. We know that higher intensity chemotherapy prior to transplant will reduce the risk of relapse, but this is always at the expense of greater toxicity and the greater risk of transplant-related death. There have been a large number of studies that have been done to try and ask the question whether a reduced form of chemotherapy versus full intensity chemotherapy is better. Some of these have included MDS patients, but there has never been an MDS specific study done. And the short answer to all of these trials is that we honestly don't know the answer in 2021. What is the right chemotherapy for all patients? The short answer is that as our ability to prognosticate outcomes increases, it will likely be MDS specific features that drive the question of whether we should be using full intensity in patients. But this is something that you have to discuss closely with your clinician. So just to summarize, despite at least 3 very well performed randomized trials, we don't know whether myeloablative or reduced intensity is superior. It's a highly individualized decision, in my opinion. And it should be based on patient fitness, patient goals for recovery after transplant, and disease risk. All of these things are parameters that should be considered. So in the last few slides, I'll just talk about a few other features that are MDS specific to transplant. As I mentioned, MDS is a disease that typically occurs in older individuals, and an increasing component of my practice is consultation for individuals that are over the age of 70 years old. This is a very active area of growth at our center and other transplant centers in the United States. It's important to understand that aging is a very heterogeneous process, right? You'll hear the phrase that age is just a number, and I do believe that that's true. We all have known friends or family that, can be 80 years old, but look, 55 or 60 and are incredibly spry and active. So I think we have to consider a patient's age, but not be married completely to that as a number, because as a numeric predictor of outcomes, age is actually a mediocre response predictor. A study that was conducted by Yvette Kazama and her colleagues demonstrated that there was no difference in the risk of non-relapse mortality in patients that were in their 50s, 60s, or 70s that underwent haploidentical transplantation for different diagnoses. So I think of age as something that is highly qualitative rather than a quantitative measure. One of the things that is emerging in the field of transplantation and others is the notion of trying to quantify age in terms of its functional or cognitive, social psychiatric components into what's typically thought of as a comprehensive geriatric assessment. At Memorial Sloane Kettering, we recently have brought on a transplant physician that has significant experience in geriatric medicine and bone marrow transplant specialist, emphasizing the importance of this component to our overall practice and transplant approach. And recently there was something called the CHARM study that was completed by the BMT-CTN, where they evaluated the role of geriatric assessments prior to transplantation. And so certainly at Memorial Sloane Kettering, in patients that are older than around 60 to 65, I do try and employ the use of geriatric specialists to help us with overall risk appraisal and assessments, and to help develop physical rehabilitation plans, for both before and after transplantation. So all of this is integrated into the sort of transplant planning and the recovery planning process. And I think this is a practice that you'll see at many other centers and is growing in frequency in the United States. So in the interest of time, I won't talk too much about the transplant process itself. In general, I think of it as kind of occupying three spaces. The first is an active transplant phase that typically occurs in the hospital, although increasingly is being performed as an outpatient. This is the portion of the transplant that involves chemotherapy and infusion of stem cells and recovery. At our center, we typically ask patients to stay for another 2 to 3 months after they're discharged from the hospital, after this acute transplant phase, for what I would call an early recovery phase. This is characterized by a rapid expansion of donor immune function and performance. Some patients can develop graft versus host disease during this time, and the risk of infections declines significantly during this period as well. Most patients, by the time they reach this sort of 3 to 4 month period after transplant, have recovered most, if not all, of their pre-transplant physical function and are sort of reintegrating back to their lives, although it's highly individualized. Everyone's a little different. We follow patients for a number of years after transplants and engage in a number of late, what are called survivorship activities, monitoring for late transplant complications, monitoring for emergence of any graft versus host phenomena, and we engage in a revaccination campaign and reintegrate patients with community physicians, particularly those that have traveled for their care at Memorial Sloan Kettering. I'll skip that slide. So I talked briefly about graft versus host disease. I didn't discuss this very much. It's a complex subject. It's graft versus host disease. At its core is the idea that the donor will attempt to reject some component of the recipient that it recognizes as foreign. If that process is just about rejecting MDS cells, then we're quite happy. But if that spills over into normal tissues, then it's a disease in and of itself, and it's called graft versus host disease. It's a complex disorder. It has a number of clinical presentations. It's typically broken down between acute and chronic graft versus host disease, the former of which occurs early after transplant, and the latter of which can occur later, and typically is more closely resembling autoimmune phenomena that can occur in otherwise non-transplant populations. Post-transplant cyclophosphamide appears to be effective at reducing all types of graft versus host disease in the context of haploidentical transplant. However, it's particularly important in reducing chronic graft versus host disease, which is this longer lasting GVHD. And the incidence of both mild and moderate to severe chronic graft versus host disease is relatively rare, fortunately, in patients that are treated with haploidentical transplant with post-transplant cyclophosphamide. So the incidence of these types of GVHD syndromes and their management is something that I think is worth discussing with your transplant physician as you prepare for that procedure. So recovery, as I said, is highly patient specific. There are a number of factors that can predict for recovery. We find that age is predictive for more rapid recovery. Younger patients do recover more rapidly from health interventions. Patients with higher SOR comorbidity index appear to recover more slowly, and individuals that have higher intensity chemotherapy, as you can imagine, require a longer recovery period. But again, this is so highly individualized and patient specific that it's something that it's worth discussing with your physician. So putting it all together, there are a number of components to the transplant plan to consider. The timing of transplant. So in my personal practice, I do not think of the availability of a matched donor versus a haploidentical donor as a factor that should influence the decision of whether or not to go to transplant. I think of those two donors as being equivalent in terms of their performance and anticipated outcomes. And so I personally let patient fitness and patient disease status sort of drive the discussion about when to perform the transplant. And the donor situation, we will find the donor for you. In almost every case, I can only think of a very small number of patients over the last decade that I've treated that haven't had an available donor. Most patients will have one type of donor available or another. So I do not let the presence of donor A versus donor B or C influence this decision to a great degree. It's really whether transplant is the right decision for you in terms of your cancer and your physical function and your life goals. I mean, all of these things are going to come into that decision. But there are a number of parameters that can be modified, as I've discussed. It's important to make sure that you pick the right haploidentical donor to maximize chances of having a good transplant outcome. It's important to discuss how strong the chemotherapy should be, both in the context of your anticipated recovery, how much support you have after transplant, different factors that you may consider to be important as you recover. GVHD prevention, it's almost always a post-transplant cyclophosphamide or Cytoxan based, but there are a number of clinical trials that are evaluating either additives or modifications to this theme, and so that's something that you may discuss with your individual transplant physician. And of course, how you plan the post-transplant, the transplant plan also should include an understanding of how you plan the recovery from transplant, and having an integrated team of physical therapists and social workers, nursing staff, and other specialists is important to consider as you work your way towards transplantation. So with that, I'll stop. I went over by quite a bit. I'll apologize in advance, but I'm more than happy to take questions. Thank you very much.
Thank you so much. We do have a few questions. Our first question is, how does umbilical cord compare to a haploid donor?
Yeah, that's a great question. There are no data that are specific to myelodysplastic syndrome. There was a recent study that was completed also by the Bone Marrow Transplant Clinical Trials Network that evaluated in a randomized fashion haploidentical transplant versus cord blood transplant. There was a survival benefit for haploidentical transplant over cord blood transplantation in that study. But it's important to recognize that there are a lot of biases in terms of how transplants are performed, what patients are considered eligible, who proceeds to transplant. So I still am not entirely convinced that matter is settled. Although if you look at transplant activity in the United States, it's clear that haploidentical transplant has become the preferred modality for performing an HLA mismatched transplant. I think that trend will likely continue.
Thank you. What are some reasons why a full biological child may not be a match for their parent?
Great question. So there are a few things that can happen in the context of when the chromosomes are split up at the time that the embryo is in development. So there is a process called uniparental disomy, and this is a process by which the chromosomes are supposed to split evenly, but in fact you get sort of 2 from one parent and 0 from another parent, and so you will occasionally find children that are fully matched to their parent, either from this process or from another process, and you'll occasionally find children that are completely mismatched. You can also see little swaps of pieces of chromosomes. These are called translocation events. They occur in roughly 3% of cases. So sometimes you'll find haploidentical related individuals that are like 5 out of 8 or 7 out of 12 matched, if you will, versus, sometimes there'll be 3 out of 8 matched. So you can see little events like that will occur. These are rare events. By and large, most of the time children are haploidentical donors. But if it turns out that your children are not haploidentically matched to you, it does happen. So, albeit rarely.
What procedures are used to lower a high antibodies prior to a haploid transplant?
These are very, very good questions. This is something that we have an active area of interest in, both in terms of developing clinical trials along this line and otherwise. I can tell you that there is a position piece that was released by the European Bone Marrow Transplant Group suggesting a specific methodology. Some things that have been tried are the use of antibody producing medications, such as a drug called Rituxan, other medications such as prednisone, and other anti-rejection drugs can be used to either reduce the function of immune cells or to reduce the presence of antibody producing cells and antibody titers prior to transplant. You can siphon the antibodies out of the blood with a process called plasma exchange or plasmapheresis prior to and even during transplantation. So all of these different methodologies have been employed in different approaches. A lot of this is based off of data from patients that are undergoing kidney transplantation. I have to tell you that at our center, we have not been particularly impressed with the ability of these procedures to work. The issue is that patients have fallen, they'll either have very low titer donor-specific antibodies. We don't think that these are necessarily clinically relevant. We'll usually proceed to transplant as is with patients with very low titer DSAs. Patients that have moderate titer DSAs, they do respond quite well to these types of interventions, but it's unclear how meaningful these moderate titer DSAs are, and it may be the case that they would have engrafted without an attempt to reduce DSA. The problem is that patients with very high titer DSAs have a lower likelihood of being able to successfully deplete these antibodies from their blood. That immune reaction is very strong, and it seems to want to persist through efforts to stop it. And so what I have encouraged, at least at our center, is trying to avoid the use of donors with high titer DSAs, either selecting a different haploidentical donor, or we have moved more in the direction of using mismatched unrelated donors in the same way that you would use a haploidentical donor. And that usually will give you the breadth to select a donor where there is no DSA present. There are not randomized trial data necessarily to compare haploidentical versus mismatched unrelated donors, but in our hands, the outcomes have been extremely similar. And I think my personal opinion is that that's generally the way forward is to first try and find a donor where there are no DSAs.
This question comes from a child whose father has MDS that is now transformed to AML. Prior to developing AML, his team had recommended regular transfusions instead of a transplant due to the risk of transplants. Now that there is AML being treated with venetoclax and azacitidine, he does have 2 sibling matches, haplo matches. His team is going to send him to transplant as soon as able. How do MDS and AML secondary patients do in general with transplant, specifically a haploid transplant?
You know, the number of transplants that are performed for AML is generally larger than that of MDS, although MDS is an incredibly frequent disease itself. In our hands, we have found that MDS and AML have generally similar kinetics of outcomes in terms of relapse incidence. MDS tends to be an older population of patients, and the number of post-transplant complications is slightly higher in those individuals. But overall, I have not found that there to be a startling difference between AML and MDS in terms of haploidentical transplant outcomes.
Thank you. And how does someone go about getting a second opinion with you?
You can find my email is at the very beginning, or I encourage you to just email me directly. If it's a very complicated question, we can set up a telemedicine type encounter, and you and I can talk about things, just like this, basically in a kind of Zoom session. Or one of my colleagues. We have a number of people here that specialize in MDS and AML specifically. I'm also on the internet. It's definitely it's easy to. I should be easy to find.
And we can help with providing Dr. Shaffer's email address as well. Yeah. And Dr. Delgado, I'm going to go ahead and get you connected with Dr. Shaffer offline. I'll connect you to by email. That way, Dr. Shaffer can help with answering your question. So I'll get you guys connected here after the webinar. So thank you, everyone. And thank you very much to Dr. Shaffer for sharing your time and your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us in 3 ways. You can send us an email at help@aamds.org. call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDS-IF Medical Advisory Board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our program. Thank you, Dr. Shaffer.
It's been my pleasure.